Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. We're so excited to have you joining us today for our briefing on type 2 diabetes, building upon a series of papers we released in the July issue of Health Affairs. Today's briefing will highlight a number of papers in the issue, and we hope it will advance understanding and advance policy to improve prevention, care, and outcomes associated with type 2 diabetes. Now, if you've read the papers, you know an estimated 37.3 million Americans have type 2 diabetes, and that's a number that's grown by more than 40% in the last decade. You'll hear as we go through the presentations today about fragmentation in the delivery system for people with diabetes, gaps in prevention, and opportunities that we have to improve prevention and care, and ultimately, of course, outcomes. All of these are the goals we have in producing today's event. Let me just spend a moment describing how we're going to run the show today. As we often do, we have two panels. The first will be a panel of researchers whose work was featured in the July issue. They'll each present their papers, and there will be time for question and answer. And then we'll have a panel discussion focusing more directly on some of the policy questions that are raised by the papers on this very important topic. Throughout the event, if you're watching live, you'll see a Q&A box below. You can enter your questions there. They'll be seen by the moderator, and we will do our best to weave those into the discussion. Short questions are easier to read than long ones, and questions submitted early are easier to get to than ones submitted right at the end of the show. But we do encourage your participation in the program by submitting your questions. We're very grateful to Eli Lilly and Company for their support for the publication of the papers and for this briefing. And before we move into the content today, I'm pleased to invite Kelly Copes-Anderson, Associate Vice President and Head of Diversity, Equity, and Conclusion at Eli Lilly and Company, to make a few opening remarks. Over to you.
Thank you, Alan, and thank you to the esteemed authors we will hear from today. And thank you to those who have joined today's webinar. Welcome. I am delighted to have the opportunity to provide a few remarks. As many of you know, diabetes is at the heart of the work that we do at Lilly. In fact, we recently celebrated over 100 years of playing a part in diabetes care. With 100 years of experience in diabetes care, we've learned many, many things. And chief among them is that we must constantly collaborate in order to modernize our health practice and health policy to support improved health outcomes. We're grateful for the collaboration led by Health Affairs and amongst the authors. Your collective expertise and collaborative approach informs and inspires today's important discussion and hopefully action ahead. Personally, I'm especially pleased to see so much emphasis on health equity throughout these papers and appreciate how the authors highlighted work that remains to be done. We all know that there's a lot more to be done. We believe with the right practices and policies in place, more people with type 2 diabetes can enjoy better health outcomes. As Alan said, diabetes, like many other diseases, disproportionately impacts people of color, and increasingly so. Diabetes together with obesity are related epidemics that must be urgently and equitably addressed. The good news is that we have made tremendous advances in innovative treatments and scientific understanding over the past 2 decades. The bad news is that despite the advances and some improvement, we haven't achieved the broad improvement in health outcomes that we all would want to see. Too many people continue to be challenged in achieving their glucose, weight management, and quality of life goals. Today, only about 50% of people with type 2 diabetes achieve the standard of care glucose management goals, and just 20% achieve combined glucose, blood pressure, and cholesterol care standards. And the most demographically and socioeconomically disadvantaged members of our community are exposed to additional care barriers and suffer the greatest diabetes and obesity-related health impact. At Lilly, we believe a modernized care ecosystem will unlock the full value of advanced approaches to care and medical knowledge. A modernized care ecosystem will be better able to support improved health equity and application of standard care approaches, leading to the better outcomes that we all want to achieve. But numerous barriers to this modern ecosystem exist, such as social determinants of health and gaps in preventative measures, inconsistent use of diabetes care guidelines not being aggressive early enough in the care journey, and outdated or misaligned quality metrics. Clinical inertia, which slows, if not halts, needed changes in therapy when treatment guidelines warrant them, and bias against obesity. Despite the clear evidence that reducing excess weight can help manage glucose levels for people with type 2 diabetes. The leading researchers we will hear from today examined many of these barriers and provided important solutions. It is our hope that this policy discussion continues beyond today's event and leads to change in policy and practice of diabetes care, improving health equity and ensuring the gold standard outcomes are within reach for all people with type 2 diabetes. Thank you, Alan, and thank you all. I'm looking forward to this discussion. Back to you.
Thank you so much, Kelly, and thanks again to Eli Lilly and Company for supporting the issue and the event today. It's now my pleasure to bring to the stage Dr. Muhammad Ali. Mo has done so much to support this issue. It's hard for me to say enough good things. He was our theme advisor. He's a co-author on the overview paper and helped really conceive of the papers that are in this group. So it's my great pleasure to introduce to you all Muhammad Ali, professor in the Department of Global Health at Emory University. He will not just present his paper, but also be the moderator for the first panel that brings in the other authors. Mo, over to you.
Thanks so much, Alan. And thanks to Health Affairs for the opportunity to help shape the whole series on type 2 diabetes, policies to improve prevention, care, and outcomes. I hope all of you get a chance to read this series because the authors that have led this work are just incredible, and they've done just a wonderful job of highlighting all the issues. So I'm just going to share my screen and start us off with the overview paper. So I'll start by, again, thanking my co-authors here, Puneet Chehal, Elizabeth Selvin, Jen Defoe, Carol Mangione, who are thought leaders on issues of policy, systems, and diabetes epidemiology. And our remit as a group was really to set the stage for everybody of what is going on with diabetes and why is there stagnation in prevention and management of diabetes, especially over the past decade. So to set the scene, we really started with the data. And as was mentioned earlier, diabetes affects 37.3 million Americans. And great work from Kay Bullard and her team at CDC have shown that 90 to 95% of people with diabetes in the United States have what we call type 2 diabetes. And so hereafter, every time I refer to diabetes, really I'm talking about type 2 diabetes. But just to say, this 37.3 million, as Alan mentioned earlier, is a 42% increase just in the last decade alone, when 26 million Americans were affected by diabetes. And critically, there's huge variation in this growth. You'll see here county level data on the prevalence of diagnosed diabetes. This is people self-reporting that they have diabetes. And the darker blue implicates higher prevalence of diabetes. And you'll see wide variation in the darker blue areas of the country. The other key important point here is that it's not just the growth in the numbers of people with diabetes, but also this immense stagnation that we've experienced. So you'll see here data from Liz Selvin and Michael Fang in the New England Journal of Medicine last year, showing that despite improvements in glucose control in the top left panel, blood pressure control in the top right, cholesterol in the bottom left, and all of these risk factors together in the bottom right, between 1990 and 2010, there's been stagnation in this last decade where everything has sort of plateaued out. The other important point here is that the averages that you see on the screen here hide even further heterogeneity, in that Black and Hispanic Americans have 1.5 times the risk of developing diabetes, of having worse outcomes related to diabetes, and poorer care. Similarly, you won't be surprised to hear that between 1990 and 2010, we had improvements across the board in complications of diabetes from heart disease, stroke, kidney disease, amputations. And those have all started to tick up after a 2-decade decline. So despite unprecedented health policy reforms in the past decade, the other thing that we're noticing is just high healthcare use related to diabetes. And you'll see here that the emergency department continues to be a big place for care for people with diabetes, and also a really good indicator of how fragmented our system is. You'll see here the dotted line shows the Affordable Care Act implementation. The black line is the national average of emergency department use for diabetes-specific complications. And the blue line is an average of 9 different states that we have data for on the right there. Critically, what you'll notice here is that white Americans not only have lowish and lower than the national average use of the emergency department for diabetes, they also have less dispersion. Contrast that with Black Americans who have 3 times the rate of emergency department use and huge dispersion across states. You won't be surprised to see that that is also shown in data related to insurance. In other words, privately insured people have less dispersion and lower rates of use, and our publicly insured, especially those with Medicaid, have 3 to 4 times the rate of emergency department use. And these numbers look the same for hospital admissions. So why are things not so good? And our group really thought hard about what is causing this. And diabetes is certainly multifactorial. It has to do with how we live, how we eat, how we exercise. But our remit was really to think within the health system, within the health policy perspective. And we thought a lot about historical underpinnings of how healthcare is governed and how healthcare is paid for and how healthcare is delivered in America. And our historical underpinnings took us to the notion that we have enormous fragmentation, a decentralized system where policy, payment, and delivery are fragmented. And short of a uniform definition for fragmentation, we searched the literature and found this working definition, which is to say that we have in America siloed and heterogeneous health services, largely because of a lack of unified goals, policies, incentives, and information across our stakeholders. And what that results in is uncoordinated, highly variable care that deviates from the evidence base. It doesn't support population health, and it doesn't support equity. So we offered this framework in our paper, which I'll tell you more about as we go on. But certainly what we noted here is that diabetes traditionally requires consistent, evidence-based, and continuous care and prevention to really address the issue. And instead, we have a lack of coordination, largely because our policies are variable between the federal government, who oversees and governs Medicare, between private insurance and employers who oversee their plans, and states who have the rights on implementation of Medicaid. Critically, there's also no continuity between them. And there's then less incentive for each payer to invest in coverage of high-value services. At the level of payers and reimbursement design, we have misaligned incentives where we pay on the basis of fee-for-service, which largely offers incentives to volume, not quality. And our services are driven essentially by boundaries around electronic medical records, where we don't have good information continuity if people move between employers, states, or otherwise. So we offer 3 reforms, largely focused on mandating a minimum package, on aligning incentives, and on getting more information that is continuous. And we hope that that offers greater consistency, higher value services, and greater continuity in population health. And a lot of these reforms came from the literature and looking at other OECD countries and what they've done over time. So I will stop here and pass you on to our remaining speakers. But just to say, given that we want to be the united and not fragmented states of America, we need to work on fragmentation as a priority. So I'll pass you on now to Maria Alva, who's an assistant professor at Georgetown University in the Massive Data Institute. And she's going to talk to you about diabetes prevention and gaps that could be addressed by effective interventions and policy.
Thank you very much, Mo. I'm really happy to be part of this panel, and also our paper was a multidisciplinary effort. I am an economist. We have 2 clinicians and a health service researcher, and so we looked at where the gaps are and try to come up with recommendations for closing these gaps. Next page, please. So going back a little bit on what prediabetes is a state where the blood sugar levels are higher than normal, but not high enough to be diagnosed as type 2 diabetes. And it's important to note that these thresholds get redefined and usually lower over time with good reason, because there is significantly increased mortality risk and cardiovascular risk as blood sugar levels increase. And not just, past the threshold, it's a continuous. However, in the past 10 years, from 2010 to 2020, we have used the same definition. And in that period, we've seen that 13.5% of the population self-reports have been diagnosed with prediabetes. And this is an increase of 4.8 percentage points, which is worrying. And when people are in the prediabetes stage, it's a good time to act because prediabetes is associated with a 2 to 10% annual risk of developing diabetes. And this risk represents a big variation. The variation is large, but from a population standpoint, even with a risk as low as 2% per year, the burden amounts to nearly 50% risk for a middle-aged person over the lifetime. Now, what are healthcare gaps? These happen in a variety of contexts, not just limited to prediabetes or diabetes prevention. Healthcare gaps are the discrepancy between the care provided to patients and the recommended best practices. Now, the US Preventive Service Task Force recommended screening for prediabetes and referral to intensive lifestyle interventions for those who screen positive. We have large clinical trials, including the Diabetes Prevention Program, the DPP study, that have shown that structured intensive lifestyle interventions that include healthy food, healthy diet, and physical activity can reduce the diabetes incidence by as much as 58% over a 3-year period. As a point of comparison, metformin reduces diabetes incidence by 31% over the same time period. The reduction in diabetes incidence from these two type of treatments are durable because we have follow-up over a period of more than 15 years showing reduced cardiovascular mortality and all-cause mortality. Next page, please. And so every decade, the Healthy People Initiative sets data-driven national objectives to improve health. And the goal for 2030 with respect to prediabetes is, number one, reduce the proportion of adults who are unaware that they have prediabetes from an estimated 32.2 to an estimated 33.2% by 2030. And number two, increase the proportion of eligible people completing the CDC recognized lifestyle modification program, the national DPP. Now, the question is, are these SMART goals in terms of being specific, measurable, attainable, relevant, and time-bound? Using that framework to rate how good our goals are, we have the S, the R, the T covered. These goals are already specific, relevant, and time-based, but they have measurement problems. So one challenge is monitoring. Awareness is kind of a roundabout way of monitoring testing rates. Testing for prediabetes nationally and longitudinally is more specific and less prone to error than estimating the proportions of adults who are unaware of their prediabetes status. The US Preventive Service Task Force took promising steps, for example, by lowering the recommended age of prediabetes screening from 40 in 2015 to 35 just last year. Now the question is, could we make the screening universal? Now with respect to the second goal, there's currently no benchmark to track progress towards the national DPP utilization goal because at the time that the goal was set, there was no reliable baseline data. And so to overcome this, the National Health Interview Survey Questionnaire in the cycle between 2016 and 2017 asked a question on utilization. And this question should be introduced at regular intervals to make it an attainable goal for participants. And maybe a benchmark should be set, maybe 50%. Page 3, the next slide, please.
And Maria, we're running short of time also, so you can...
Let me just go super fast. So here we're showing the estimates for undiagnosed prediabetes. And this illustrates well the point I was just making before on the measurement problem. So first, how do you define undiagnosed prediabetes? So here we use a definition using the questionnaire from the American Diabetes Association, the score. So a score greater than 5 on that metric means that you have prediabetes. And so the difference between what you score in the test and whether you have been diagnosed or not shows the undiagnosed prevalence. So the test has 7 questions. You get points for these questions ranging from 0 to 11. But you can see already, how that can be problematic. So using that definition, using the ADA algorithm to determine risk, we find that 30% of the population is undiagnosed. And the undiagnosed rate in women is 15% points lower than in men. And the reason for that is that for women, we have universal testing for gestational diabetes, at least during pregnancy. And people with no insurance are kind of faring equally, if not worse, than people with Medicaid. And almost 63% of people in Medicare are not aware that they have prediabetes. Now, this may be a feature of the algorithm itself, because one gets automatically 3 points when one is over the age of 60. Next page, please.
Maria, I'm going to ask you if it's okay to review those in about 1 minute, if that's okay.
Yeah, sure.
Thanks.
Do you want me to go forward, or?
Sure. Yeah. Just to perhaps bring together everything in the coming minute, if that's okay. We're just running way over. So here we're illustrating uptake. So nationally, 3% of people have taken part in the DPP program, and so we ask why that is the case. There are different reasons. For example, the number of sites is limited. There are no sites in some states. Even in the Medicare program that is a mandated cover benefit, there are no sites in 4 states. 50% of them are employer-based and require some form of membership. In addition, people must have a BMI of at least 25 or 23 if they're Asian Americans to participate, and that excludes 20% of the population with prediabetes that have a lower BMI. Not all people not all people are eligible to participate. Especially troublesome is the case with the Medicaid population. Not all states offer this as a covered benefit. And that makes roughly 80% of the population that is not able to participate and doesn't have access to sites. Next slide, please. So basically, what are the solutions in brief? We report a number of these. Number one, many providers have been vocal and stating that the cost of the delivery in the program exceeds the reimbursement amount. So as a response to this, CMS has increased considerably the reimbursement rate for patients. But a lot of questions remain. Is pay for performance a good model? Is it good for diversity and our reach? The DPP requires the luxury of time and money, and this is a year-long program, and healthy food is expensive. And we know that historically, white patients have performed better in the DPP compared to other groups. Another question is, are there any perverse effects of having different payment mechanisms? So pharmacological interventions are covered at the point they are administered, and DPP is covered with a substantial lag, and the coverage is uncertain because it depends on the performance of the patient. Next slide. It will be great to increase improve data integration and patient follow-up. We have great examples of institutions that have developed innovative and effective methods for screening and reference using electronic medical records, but there is a lot of variation nationally, and not everywhere screening is standardized. So we have a number of missing opportunities to connect people with services. One great example is that we have universal screening for gestational diabetes during pregnancy, which is a unique opportunity for them to identify women at risk of developing type 2 diabetes. But post-pregnancy, we haven't really, we're not good at following up people. Is it due to lack of insurance or lack of follow-up? And number 3, extend the coverage and broaden access. So the DPP may not be the solution to the gap. As I mentioned before, the DPP works, but requires time. It's a weekly commitment for 6 months and then a monthly commitment for the rest of the year. So piggybacking on my previous point, during pregnancy, medical nutrition therapy alone seems to work really well. It achieves adequate sugar control for 80% of women. It's only 90 minutes visit followed by 3 other visits in a very short amount of time. That could be a good option. Metformin as well.
is indicated by the ADA, but is not yet FDA approved. Next page, please. And just
Thanks,
the last
Maria.
point.
Oh, go ahead.
The last point is population level interventions. The most promising one seems to be taxes for sugar beverages. For example, if you compare the impact of the taxation of sugar of SSBs on weight loss, it is 0.5 pounds weight loss compared to 1.3 pounds loss for a population level DPP. So in Finland, who has a population of just 5 million people, 1.5 million people in 5 different regions were offered a DPP for 3 years. And so it's a better effect, yes, but if you consider the cost benefit, taxation is revenue generating. There are other ideas of population interventions that we should apply that are less costly and require less time. And so these are our 4 recommendations. And finally, the last slide is just the 2 main takeaways that and a call for action, that we need to follow best practices, and the best practices should not be determined of where we are and what is our payer type. And I stop here, and I apologize for running over.
Thanks, Maria. We'll talk more about it in the discussion. So now I'd like to introduce Dr. Tom Bodenheimer, who's a professor at the University of California, San Francisco, who's going to talk to us about care management. Tom.
Hi, everybody. This was a paper done by myself and Rachel Willard Grace, who's the director of the UCSF Center for Excellence in Primary Care. Next one, please. So in the past, and unfortunately still too much in the present, diabetes was taken care of in primary care with very short visits, like 15 to 20-minute visits with 6 agenda items. And so there was about 2 minutes for the physician or the nurse practitioner or physician assistant to actually spend time with a person with diabetes. This changed greatly with the advent of the chronic care model, which was pioneered by Ed Wagner. And one of the key points of the chronic care model is we need to have a very different way of taking care of people with chronic illness than people with acute illness. And so we need really planned visits for people with chronic illness. So a planned visit is a visit in which the only agenda item is the person's chronic illness. And generally planned visits are done not by the physician, because when the patient comes to see the physician, they want to have all of their agenda items taken care of. So usually often it's a nurse or a pharmacist who's trained in care management, who spends maybe half an hour with the patient, and you can really do a lot of work with someone with diabetes if you have a planned visit with a trained care manager to do that. Next one, please. We can skip this, I think, go on to the next one. So what is care management? So care management, so what happens during these planned visits with nurses, pharmacists, or behaviorists? First thing is making sure that the patient understands what diabetes is. And this is done really in an ask, tell, ask methodology, not telling people what to do, not telling them all the things, but finding out what they want to learn, finding out what they want to do, finding out what they're willing and able to do to improve their life. So one thing is the education. Second thing is healthy behavior change, which is done by health coaching, not by telling people what to do. And then finally, really good care management includes looking at the patient's laboratory values and then adjusting medications based on those laboratory values. And care management that's the most effective is when the nurses or pharmacists have the authority to make changes in the medications based on the lab values. So there are many, many studies that are cited in our paper that show that care management really does work to improve diabetes outcomes. Next one. So who are these care managers? The most likely ones are RNs, pharmacists, and social workers, other behaviorists also. So why aren't we doing care management everywhere in primary care? Because remember, the chronic care model suggests that that's the way to take care of people with diabetes, but unfortunately, it's not happening in most practices. What are the major barriers for this to happen? Number one, inadequate numbers of these professionals trained in care management. So there are, for example, there are a lot of pharmacists in the country. You know, the number of pharmacists is adequate, but the number of pharmacists in primary care is relatively small, and most of them don't learn in pharmacy school the parts about care management, which is somewhat of a different science than the other kind of work that pharmacists do. Same thing with nurses. Very few nursing schools spend a lot of time on ambulatory care nursing. It's almost all hospital nursing. So even though, of course, the whole issue of nurses has changed dramatically with COVID, so there really aren't enough nurses. There may not be enough nurses in the country, and there certainly aren't going to be enough nurses in primary care to do the care management that we would like to have for everyone with diabetes. In addition to the inadequate numbers in primary care, there are a lot of regulations that prevent these care managers from utilizing the skills and competencies they possess. So for example, we talked about care management's most effective when the nurses or pharmacists can actually make changes in medication doses based on the patient's lab values, but a lot of regulations in many states prevent them from doing that. Usually the health education and the behavior change parts of care management can be done under state regulations. It's more the medication changes that is a problem. And finally, payment is a very major problem because generally in primary care, nurses are more of an expense than a revenue. Same thing with pharmacists. Social workers often can actually pay for themselves by billing, but these payment policies have to be dramatically changed to allow care management to take place widely in the United States. Next one. So 76% of diabetes visits take place in primary care. However, primary care is grossly under-resourced. So primary care has a lot of work to do and very little money to do it. So what can we do to stimulate the widespread adoption of diabetes care management? Number one, value-based primary care payment that financially supports care managers, modernization of the restrictive state regulations, and most importantly, an increase in the percent of the total healthcare expenditures going to primary care. Currently, the United States spends about 5% of the total healthcare expenditures on primary care compared to countries in Europe that spend maybe 12%. We really need to increase the percent of the total healthcare expenditures going to primary care from 5% to 10%. That would be very, very helpful in terms of stimulating the widespread adoption of care management. Thank you.
Thanks so much. That was terrific. So to carry the conversation further and step outside the clinic, I'd now like to open the floor to Dr. Leonard Egede, who's professor of medicine and a health equity chair at the Medical College of Wisconsin. Leonard?
Hi, hey, thank you so much. I'm really excited to be here. I just would first apologize. I'm on vacation, so I just had to make a decision whether to join in or not. So I'm here, and I'm going to try to go through my slides. So this is a team effort. It was a group of investigators at the Medical College of Wisconsin. We actually worked on this extensively. Next slide. And so really what led us to this whole idea was that we all know that diabetes confers significant risk for morbidity and mortality. The disparities are well described across socioeconomic status, race, ethnicity, gender, sex, age. And then there's also literature linking social determinants of health to diabetes outcomes. So we really know that there is some importance of non-medical aspects of diabetes care that needs to be addressed. And more there's conversation now about integrating medical and social care. Next slide. And so what we've observed is that there's less emphasis on non-medical interventions or the integration of social determinants of health. So while there's a lot of talk about social determinants, a lot of literature coming out now, there's really less of that integration and more awareness of how much effort it takes to actually take care of diabetes outside of the medical establishment. And then we've also, as we begin to talk more on structural racism, structural inequalities, there's less and less of an awareness that these are actually antecedent to social determinants. So while we're doing a lot of work on social determinants, we need to pay attention to the upstream factors, high-level factors that drive some of the social determinants. And then we also need evidence for non-medical intervention. So what works at the non-medical level? So these were all the things that that led us to actually work on this paper. And then we also were thinking about what are some of the actionable strategies, what are some of the policy-informed opportunities that may allow us to address disparities as it relates to diabetes. Next slide. And so what did we do? We did a systematic review of studies. We looked at multiple databases. We looked at studies all the way through January of 2022 that were conducted in the United States. They were in English. And our goal was to identify what's been done in terms of interventions that were actually clinical trials or quasi-experimental design. We even included pre-post designs to look at, in a population of adults at risk or with type 2 diabetes, what are some of the interventions that are non-medical that have actually been done, and the outcomes for A1C, blood pressure, lipids, self-care, quality of life as an outcome. And of course, we use our standard expectations, PRISMA guidelines, merge terms. We did a reproducible search, looking at PubMed, Cochrane, and Medline. So very extensive set was done. Next slide, please. So what did we find? A couple of things. One was that I think the most important thing was the very few studies. So we actually, when we got done, we probably ended up with about 6 to 8 studies that actually were well done and that actually focused on this. But what we did find was that these interventions that were targeted, they had to be multi-component design, and they had to combine both medical and non-medical approaches. And so it's very clear that if you're dealing with a disease like diabetes, just doing non-medical without accounting for the medical is not going to be a good strategy. So most of these studies actually combine a baseline of some level of medical component, education, skills training, and then added some of the non-medical pieces. And so for A1C levels, which is glycemic control, we found 4 broad areas where there was evidence of efficacy. One is food supplementation with referral and diabetes support. And so again, with the food supplementation, without taking care of the diabetes, you also, you needed a combination of both. Then other thing that's really very strong right now is financial incentives when it's combined with education and skills training. And so we've done several studies on incentives, and in my career, I've seen the largest effect in glycemic control from the financial incentives. And then the third thing we found was using housing relocation with counseling support. And the last was integration of non-medical interventions into medical care using the EMR. So really trying to integrate some of those processes. Next slide. And so we also found that based on the gap that we identified, we actually decided to focus on some policy opportunities. Things that we saw were areas where opportunities that could actually change the landscape for diabetes. And so the 5 areas we identified that we felt were really important, and I'm sure the panel will have some discussions about this. One was Medicaid expansion. How do we expand Medicaid coverage, especially for lower income individuals who may actually have chronic disease? Then the second is really to think about how do we ameliorate vulnerabilities of our health system in terms of systemic shock. So the pandemic has really shown us that our systems are very vulnerable, especially safety net systems. How do we create buffers for these safety net systems to ensure that they are not, they can continue to function in spite of the systemic shock? Then expand and establish new billing practices for uninsured patients. We found now that a lot of catastrophic healthcare expenditure are tied to the uninsured patients because of child master rates. And so how do we ensure that individuals are actually aware of what they're being billed for and making sure that those billings are fair and consistent with what is usual and customary? And then we also talked about policy levers that focus on the labor market. So things like social mobility, social infrastructure, minimum wage, paid time off. How do we ensure that people are not able to function when they have chronic disease. They actually have the resources and they have the ability to actually take time off to go take care of themselves without putting their health at risk. And then we also talked about expansion of the existing HOT programs. So things like community development block grants, housing choice voucher programs. These are programs that are likely to be effective, and some preliminary evidence as interventions that will really help individuals who are lower income, more at risk in terms of helping them manage having a safety environment that allows them to be able to function when it comes to health and healthcare. I think last slide, please. And so we concluded, and this is the quote from Health Affairs, the results of this review highlight the potential for positive impact when interventions address both social and medical needs. Thank you.
Thank you very much. And so taking us back into the medical sphere and thinking more about equity and quality metrics, we have Rosalina McCoy, who's an associate professor at the Mayo Clinic, to talk to us really about reforming and modernizing quality metrics for diabetes. Rosalina?
Thank you so much. And it's truly, I think, an honor to follow these series of talks and really build on them to see how can we leverage quality measurement in order to truly support the pursuit of quality in the management of diabetes. So I'm here on behalf of my team, and I really want to acknowledge their work and incredible contribution to the study and paper. So first, I think we need to appreciate that the goal of quality measurement is improving quality in that holistic sense of the term, right? So specifically improving both how we deliver diabetes care and then the quality of the care that we deliver in order to ensure that people living with diabetes live the best lives possible and that their disease poses the least burden to them, their communities, and their whole society. And with that in mind, I think we can see that current quality measures don't really measure and by that incentivize quality. So in this paper, we discussed ways that quality measurement can be reimagined and realigned to truly align measurement with quality that we seek to pursue. So as you likely appreciate, there are currently many dozens and dozens of quality measures that focus on some aspect of diabetes management, especially those of us in primary care or policy. And these measures are developed and tracked by a multitude of organizations, often with slight variations on pretty much the same theme, but all asking the healthcare system to be measuring some aspect of what they're doing or how their patients with diabetes are doing. But these measures don't measure quality in that holistic sense of the word. So if we think about what is quality, it covers 6 different domains: effectiveness, efficiency, safety, timeliness, patient-centeredness, and equity. Yet almost all measures that are in use today are measures of just effectiveness. So they assess whether patients are receiving evidence-based care that achieves desired goals, that is, reduces the risks of complications, controls symptoms, or improves quality of life. But even there, we still have many opportunities to improve these measures by focusing on hard outcomes that matter to people living with diabetes, rather than surrogate measures that have some degree of association or correlation with the hard outcome that we're trying to prevent. But at least we are doing this. Efficiency measures, which we can also think of as value measures, they consider cost of care or utilization of low-value services. And there are some measures in this space. We look at total costs of care, hospital rates, risk of readmission, but we can really build on this and think about the efficiency of how we deliver care. Is there waste? Is there alignment of treatment intensity with how much the patient benefits from that particular treatment approach? Are we using the correct medications in the correct patients? There are also some safety measures which are really a countermeasure to effectiveness measures. There are some indicators, such as looking at severe hypoglycemia, risks of hospitalizations, hypo or hyperglycemia that may occur in the hospital. But again, we can do a lot more. We can look at medication errors, overtreatment, undertreatment. All of them would fall into that category. And importantly, there are no measures for timeliness, patient-centeredness of equity. So to give you an idea of what we imagine for these measures, timeliness measures could imagine therapeutic inertia, such as failure to intensify glucose-lowering medications if patients have high glucose levels, or to de-intensify if they experience hypoglycemia or are overtreated. Measures of patient-centeredness would assess the process of shared decision-making in diabetes care and whether treatment plans align with patients' goals and preferences. Patient-reported outcomes could be assessed through patient-centeredness measures that include aspects of care such as treatment burden or quality of life, fear of hypoglycemia, psychological well-being, diabetes distress or depression. And there's, again, no existing measures that address or promote equity. And that needs to happen across all domains of social determinants of health: racial, ethnic, socioeconomic, geographic, and organizational. So as we think about how do we improve measures, we propose three propositions to realign measurement with quality as we pursue it. So first, we need to develop, validate, and implement new and modernized measures across all 6 of these domains of equity. Now, these measures ideally would be rigorously tested and demonstrated to have meaningful impacts on patient health outcomes, quality of life. Now, once we develop these holistic sets of measures, they should not all be used. Instead, we propose that they be a purposefully selected, narrow subset of measures that are used as top-line measures for public reporting and reimbursement, akin to the myriad of measures that are used now, just be selected really thoughtfully and purposefully with the goals that we're trying to achieve. And these should prioritize hard outcome measures that matter to people living with diabetes and surrogate outcome and process measures that accurately, reliably, and appropriately capture evidence-based care and reduction in the risk of experiencing adverse health outcomes. Again, thinking about what is it that we're trying to achieve. And then the remaining measures that are not used as top-line measures should be used for evaluative purposes at all levels of the healthcare system to help each of those levels identify and address factors that contribute to gaps in diabetes quality and outcomes. So to address thinking about the challenges that we may face in implementing kind of this reimagined approach to quality measurement, I think we need to think about purposeful risk adjustment. Risk adjustment should lessen, not exacerbate disparities. And importantly, they should incentivize the care for patients with complex needs. It's going to be important to measure correctly aspects of quality impacted by different levels of the healthcare system, because as Dr. Gady just suggested, the vast majority of factors that impact health happen outside of the healthcare system, and we need to think holistically about the whole continuum of what impacts our patient health. We need to address systemic barriers to healthcare and to health and promote cross-level collaboration. We need to measure quality at appropriate and actionable levels of the healthcare system and society, thinking about what measures are appropriate, useful, and actionable at the clinician or care team, clinic, health system, county, state, health plan, or payer levels. We need to ensure that all people are counted, including those with barriers to accessing care who have historically been excluded from all of the denominators simply because they can't access care. And that's where leveraging population-level data can be incredibly useful. And finally, echoing what has been said before, we need to strengthen value-based reimbursement models to make value-based care and quality measurement truly able to impact the care that we deliver and the care that our patients receive. And I really hope that you can read more about each of these challenges and what we propose in the paper. So thank you.
Thank you, Dr. McCourt. So it's a perfect segue to introduce you to our last speaker of the author series, and that's Sabrina Wang, who is a research associate at the Obesity Research Center and an MD candidate at the University of Chicago, who will tell us all about alternative payment models and value-based insurance design. Sabrina.
Thanks, Dr. Ali, and hi, everyone. It's really an honor to be here and to be able to speak on behalf of my co-authors. As we've already heard today, diabetes is a condition that has immense health policy consequences, both in terms of potentially devastating impacts on individual patients' health and in terms of overall cost to the healthcare system. And optimal diabetes care requires care coordination across healthcare providers, active engagement from patients, and interventions that target the social determinants of health that impact diabetes outcomes. And as payment reform initiatives often address, or at least aim to address, some of the above domains, our paper explored how 2 areas of payment reform might impact diabetes outcomes. So first, we performed a scoping review of alternative payment models, or APMs, which aim to improve care quality while reducing costs. In contrast to traditional fee-for-service reimbursement, APMs link physician and hospital payment to the value of care provided rather than the volume of care provided. And by centering care quality, APMs can encourage providers to make upfront investments in care coordination, patient education, and interventions targeting health-related social needs. We also examined value-based insurance design, or VBID, a benefit design strategy that aims to improve patient medication adherence by reducing out-of-pocket costs for high-value treatments, in other words, those associated with improved health outcomes. Many VBID programs focus on reducing co-payments for prescription medications, and diabetes is a natural application for this strategy, as the cost of medications has caused some patients to ration insulin, and medication adherence is very important for blood sugar control. So beginning with our results examining APMs, and to guide our discussion, I've adapted the HCP-LAN APM framework graphic here, which categorizes payment models based on levels of financial risk assumed by the provider. Category 1 on the left here, it reflects no risk. So for example, full fee-for-service Medicare. And category 4 on the right reflects full risk. So for example, full capitated payment, such as global budgets. Categories 2 and 3 are intermediaries between the two. So we analyzed 13 studies across various levels of risk, 5 category 2 or pay for performance models, 5 category 3 or shared savings, shared risk models, and 3 category 4 or global budget total cost of care models. Most of these studies evaluated process measures such as routine A1C testing as opposed to outcomes measures such as A1C control. And I mentioned that as has already been mentioned today, that improvements in process measures do not always necessarily track with improved outcomes for diabetes. I want to focus a bit more on 2 example APMs to lend greater context to the types of impact that we saw. And I include these examples here both because they're landmark APMs and also because they're somewhat emblematic of the larger trends that we witnessed. So first, we identified an evaluation of the Medicare ACO Shared Savings Program. This is a Category 3 APM or shared savings model. And in the time period evaluated, most ACOs were in upside risk only models. So in other words, they were rewarded for lowering costs, but not penalized for increasing costs compared to historical benchmarks. So in the first year of the demonstration, ACOs showed significant but modest improvements in LDL cholesterol testing compared to control groups, and there were no significant differences in the other measures studied. Next, I want to highlight a Category 4 APM, the Massachusetts Alternative Quality Contract, which is a global budget implemented by Blue Cross Blue Shield Massachusetts. This contract paid providers a global budget covering the entire continuum of care for a defined population of enrollees each year. And in the first year of this demonstration, the model reported significant improvements in all process-related quality metrics, the largest of which was a 5.5% increase in eye exams. And I'll just note that I included the first year demonstration numbers here for ease of comparison, but these improvements actually increased in magnitude in year 2 of the demonstration. And before moving on, I want to mention that the results of the Category 2 or pay for performance models were mixed. So some papers reported positive associations between pay for performance and diabetes quality measures, while others reported negative associations. So moving on to value-based insurance design, we examined 11 evaluations focusing on the medication management of diabetes. Most of these studies were implemented by health plans or employers and were pre-post comparisons, which limits study strength. 7 of the studies reported small increases in medication adherence associated with VBID, and most of these were small, less than 5%. And although most studies primarily examine medication adherence, I want to highlight a recent study by Warham and colleagues that looked at outcomes. The authors found that reducing co-payments for diabetes and cardioprotective medications to 0% was associated with a 16.2% decrease in ED visits for acute diabetes exacerbations. So in summary, the past few decades have been a time of intense experimentation within payment reform, and we believe it's crucial to routinely evaluate which experiments have shown results and which haven't. Amongst the studies that we identified, we found that APMs that place greater risk on providers, such as global payment and shared savings models, tended to show greater improvements in diabetes quality metrics compared to lower risk pay-for-performance models. We also found that some VBID models have reduced patient out-of-pocket costs for medications and modestly improved medication adherence. However, for both the APMs and VBID, we found very few studies that examine outcomes rather than process measures. And in all, these results demonstrate that though these two payment reform initiatives can definitely play a role in stemming the tide of the diabetes epidemic, neither of them are silver bullet solutions. I mentioned earlier that diabetes is a condition for which care continuity and coordination is particularly important. And with the payers and payment models that exist within the US, there is significant fragmentation within our healthcare system. And the proliferation of payment models over recent decades can definitely add to that sense of fragmentation. So we believe that a broader alignment of incentives is necessary to ensure high quality diabetes care. Short of a larger overhaul of the US healthcare system, there are a few areas that we can prioritize moving forward. First, it's worth noting that nearly all of the papers we identified did not study Medicaid. Most experimentation was contained within the Medicare and commercial sectors. And as diabetes is a condition for which marked racial and socioeconomic disparities persist, it's crucial to expand payment reform work to Medicaid to ensure that innovative strategies are being used to promote health equity. Second, policymakers should continue to standardize and expand quality metrics, which can help promote alignment and encourage provider organizations to pursue more comprehensive programming across payer populations and reduce administrative burden from multiple quality measurement approaches. And finally, policymakers should consider integrating APMs and VBID under a single payment model, as the effects of these experiments in isolation appear to be moderate at best. Broader alignment of payment reform efforts combined with the increased investments in the primary care safety net can help maximize impact. That's all I have for you today. Thanks for your attention.
Thank you so much, both to you, Sabrina, and then to all the authors. So we have just a few minutes, probably about 12 to 13 minutes to talk and to get some questions from the audience. I'd like to start really down at the micro level and ask Dr. Bodenheimer a little bit about, there was a question from the audience from a health psychologist about what sort of systematic health behavior change training is really needed for nurses, social workers, and pharmacists to be able to sort of act on and help change behavior, both at provider levels and patient levels.
Well, thank you for that question. Unfortunately, a lot of physicians and sadly, some nurses also still relate to patients by telling them what they have to do. And if they don't do it, they call them non-compliant. Unfortunately, that unhelpful, anti-patient way of thinking about things still persists, but little by little, we're making progress. So certainly motivational interviewing has been very helpful and should be the basis for how to talk to patients about diabetes, which is really to only suggest things in terms of behavior change that the patient is willing and able to do, which means using ask, tell, ask to find out what patients are thinking. Now we've done a lot of training at our Center for Excellence in Primary Care on what we call health coaching, which is basically that whole paradigm of finding out what people are willing and able to do, see what they want to learn, and engaging them in that way, and moving towards patients setting their own goals and then creating action plans, which are very small steps toward those goals. So thank you for the question. Very, very important that we have this new paradigm on how to interact with patients for behavior change.
Thanks. So building off of that and going to Dr. McCoy and thinking a little bit about quantity and quality measurement, the idea of sort of administrative burden, administrative waste in American healthcare is sort of at slight odds with quality and quality measurement. And I wonder how you think about as we reframe towards and or reform these quality metrics, is there a way to do it without the waste, or is that just a given?
That's a really important point, and actually it was one of the things that was at the forefront of what we're thinking about as writing this, because for us, efficiency in quality measurement is just as important as efficiency in the care itself, because we don't want to have that waste. And I think that was the primary reason why we really wanted to have a narrowly defined, purposeful, kind of centralized set of those top line measures that are going to be used by everyone for public reporting and reimbursement and the value-based payment models in order to avoid all of that waste. All the other measures, they could exist as an arsenal and a tool set for all levels to use to improve what they're doing, but wouldn't be mandated for reporting. So ideally, this is a place for HHS really to lead and to identify all of those top-line measures so that there wouldn't be waste. And there also wouldn't be gaming of the system, as health systems get to pick and choose which particular measure or sets of measures they want to follow in a particular year, depending on how they're doing and what they're doing.
Yeah. Can you speak just a little bit more about public reporting and the experience in Minnesota, for example? Mm-hmm. Has that actually improved quality outcomes and specifically health outcomes for people with diabetes?
Yeah, so in Minnesota, for diabetes specifically, so you're referring to the D5. It's a composite indicator of 5 measures, 5 surrogate or process measures of diabetes care quality that every single healthcare system and clinician in Minnesota have to report. It is used both for reimbursement and for public reporting and kind of publicly available to all. There's some evidence both from the D5 as well as from other quality measures, mostly for hospitalizations for pneumonia, MI, and heart failure, that public reporting does somewhat improve quality. I can definitely speak to measures that are tied to reimbursement. They drive prioritization of resources and focus. Whatever is measured and tied to money becomes the focus of everything that the health system does. So I think in that way, quality measurement and reporting will drive at least effort and attention on those areas, which again is why we need to be purposeful and have really a structural approach to what we're going to measure so that we're pursuing quality for all patients, and it's not on the whims of the individual systems.
Thanks. You bring up money, which is a great segue to Sabrina. And this question that I've been pondering a little bit about, the more we tinker with these systems, with alternative payment models, value-based designs, and all these things, over time, if we want something simple and the more ingredients we add to it, do we get a more complicated mess that is hard for us to actually operate into the future and actually addresses any of the fragmentation?
I think that's a really great point and something that was, really top of mind for us as we were formulating this paper. This is not something that ended up in the final version that was published in Health Affairs, but in drafting, we actually spoke quite a bit with the folks that run the ACO contracts at UChicago Medicine. And one of the things that we really walked away with was this impression that the proliferation of payment models, payment reform models over the past few decades has increased fragmentation, not just nationally, but within individual provider organizations. UCM, like many other hospitals, is running a variety of APM contracts across different payer populations, categories of risk, and payers. And this can make care coordination and management for chronic conditions like diabetes extraordinarily difficult. And I think fragmentation is something that is really top of mind nationally in terms of the conversation related to Medicare for all, in terms of the conversation related to, the public option. And I don't think I'm personally equipped to speak on these broader reforms needed to really address fragmentation on a national level. But I do think that the policy proposals that we put forward in the paper in terms of expanding payment reform to all populations, including Medicaid, in terms of standardizing and expanding metrics, and harnessing the power of different payment reform initiatives and combining them, those can all be first steps for us to ensure that as we iterate on the designs of these payment reform initiatives, that we aren't actually making the problems worse.
Thanks, appreciate that. Dr. Agede, there's a fair amount of interest in the chat about structural racism. And I know you mentioned that the literature and in the systematic review that you guys did is extremely thin in that space. I wonder if you can speak to maybe active studies that are going on that haven't yet been published, or work that you are involved in that might be starting to show some promise, and how to address such deep-seated issues in the United States.
Yes, so I think we have a systematic review that we're working on right now to really look at one, how do we define systematic racism or systemic racism, and how does it impact diabetes care? So we're working on that for diabetes care, but I think the bulk of the work right now is really trying to use redlining as a surrogate for systemic racism. And so we just published a paper in Diabetes Care where we use data from Seattle to look at the impact of systemic racism or redlining on mortality and health and years of life lost. And there was a very significant impact. We're doing the same work now, looking at it in Wisconsin, where we have very strong data on redlining. So I think redlining right now is about one of those factors. It's not the only one, but it's one of those factors that would be a good way to really look at historic impact of systemic racism. And then in terms of interventions, I think the interventions are going to be a combination of systems level interventions, things around policy, things around housing. So that's why some of the actionable strategies we suggested in this paper are going to be things that will actually have a chance to touch on systemic racism. One other factor that I think we're not all paying that we may know about is really this concept of gentrification. So what gentrification is doing now is that you're having neighborhoods that were historically redlined, historically poor. You bring in a new group of individuals who are typically more affluent, and you essentially change the environment and make it very difficult for those who already live there to continue to be able to afford those. So these are all factors that we need to pay attention to, and we're actually beginning to study to see how that impacts health and health outcomes.
Thanks, much appreciated. So, and last question is for Dr. Alva. And thinking a little bit about, we've talked a lot about value-based designs, this idea of incentivizing better care through pay for performance. And you described pay for performance as already active in the national DPP in terms of how payers reimburse for that. Can you speak a little bit towards to whether that is working, or is that actually a problem for prevention of diabetes?
So we know that many providers have been really vocal in stating that the cost of delivery in the DPP far exceeds the reimbursement amount for at least the Medicare DPP, and CMS has been responsive to that. In fact, just early this year, they increased the reimbursement amount by over 50% for those who lose the 5% weight loss benchmark, and by over 100% for those who do not, right? Because there's different payment for those who meet the benchmark criteria and those who don't. But I think there are a number of questions that remain unanswered. For example, I mentioned that, is it good for diversity? We know that certain groups perform better than others. Will we be cherry picking patients in that sense? We don't have evidence on that thus far in the racial composition, but it's something that we need to monitor. And I guess there is also an issue that I think we need to study, and I'm particularly concerned about, is are there perverse incentives into cherry picking the actual programs that we offer to patients? If we have a menu, which currently we don't have, but if we were to have a menu of different programs that we can offer to patients, are we more likely to offer patients that give a certainty of payment versus those who have this uncertainty in payment?
Thanks. I wish we could keep going because there's so many more questions. And I hope any of you in the audience who have more questions, please do reach out to each of the authors. Their email addresses are in the issue. Alan, I will turn it back to you. It's been a terrific session. Thank you all.
Thank you so much for leading us through the papers. And I'm now pleased to turn to the second portion of today's program, which is a panel discussion. We have 4 panelists. The first is already well known to you. Dr. Ali will be joining us here. He'll be joined by Tiffany Gary Webb, Associate Dean for Diversity, Equity, and Inclusion, and Associate Professor in the Departments of Epidemiology and Behavioral and Community Health Sciences at the University of Pittsburgh Graduate School of Public Health. We have Joe Selby, former Executive Director of PCORI, the Patient-Centered Outcome Research Institute, and Mark Fendrick, Professor in the Division of General Medicine in the Departments of Internal Medicine and Health Management and Policy at the University of Michigan, Director of the University of Michigan Center for Value-Based Insurance Design, VBID, a term you already heard earlier in the program today. So welcome to our three new members of the panel. What we're going to do, first of all, I just think it's important for the audience to get a couple of minutes of introduction to each of you where you can talk a little bit about what your relationship is to the topic. And then I'm going to walk us through a number of topics that have come up in the discussion thus far where we can have a bit more of a policy focus. But Mo, I know you've been doing a lot of work already in this session, but I'll turn first to you. Just say a little bit more about your direct engagement with diabetes care and diabetes policy.
Yeah, absolutely. Thanks so much. So I co-direct a center that studies diabetes, and I've done that for a number of years. And so we have a number of grants and other things that really think very deeply about the epidemiology of diabetes, what we can do to really implement diabetes prevention and care better, and what policies can facilitate that. And so that's the angle at which I come at this from. And in sort of reflecting on the issue, as you know, in our piece, we provided sort of the 30,000-foot view of why is there stagnation in diabetes prevention and care in the United States. And part of what I've been thinking about, broadly with our 30,000-foot view, in addition to the data, there are really complex issues, one of which is fragmentation. And thinking a little bit about why did that come about? I've been reflecting a lot on sort of other OECD countries and what makes the United States so different. And my 2 or 3 broad reflections were, number one, people with diabetes don't spend all their time in clinical care. They probably spend less than 1% of their lives in clinical care. And yet we don't have systems that can reach them and sort of facilitate their self-management in the communities in which they live, in the workplaces that they go to work, in the places of worship that they go to. And unlike all the other OECD countries that we know, the United States really has no social welfare systems, no ways to access people in their communities. And as Dr. Bodenheimer mentioned, incredibly low primary healthcare spending. And so what this means is that we have this enormous reliance on payer groups, on health systems to be the delivery group, and then clinicians to be the sort of conduit to remember everything and to try to coordinate and navigate people's lives and health. And I think what that ends up doing in the framework that we've created of decentralized healthcare and a fee-for-service reimbursement model is that we have transactional healthcare, not relational healthcare. And as I mentioned, we just really have this focus on everything is clinical, everything is within health system and health policy. And so I think we need to get away from that. Within health systems and health policy, as mentioned in our paper, we think there's just enormous fragmentation at the policy level, at the payment level, and at the delivery level. And what it means is that there's very little mobility allowed, and people can't move between payers. We segment everybody very carefully. They can't move between payers, they can't move between states, they can't move between employers. And so this makes it very difficult for a chronic disease like diabetes, where you need that continuous evidence-based care. I'll stop there and pass on to the next speaker.
Who is the next speaker?
It looks like Alan is frozen.
Okay, I'll go ahead and start while we're waiting for Alan to come back. I'm Tiffany Gary Webb, and I'm a social epidemiologist working in the understanding the social determinants of diabetes and cardiovascular disease for a number of years. And I come at this from a number of different perspectives. So early in my career as an epidemiologist, the cohort studies weren't necessarily measuring all of the social determinants. We didn't call them that then, but social determinants that I really thought were contributing to especially disparities in diabetes for Black populations and other underrepresented populations. And so I started my career working with general medicine clinicians and behavioral clinicians, looking at care models that included community health workers. And so this included, with the care management that has been talked about earlier with nurse case managers, it put a community health worker component where the person worked with the actual diabetes patient in their home and worked on social determinants such as family issues, food, and physical activity. And so that was a large part of my early career, is doing that intervention work. I then transitioned to look more at from an observational level at social determinants when more data became available in that area. So we started to link neighborhood level data on food stores and on the built environment and on other revitalization to diabetes outcomes. And so I spent a lot of my career contributing to that evidence base. And so recently, it's kind of both of those areas have come together. So I have focused on diabetes prevention, but from the standpoint of trying to make the standard model translated to mostly Black populations and other underrepresented populations. And so looking at how we can tweak components of that diabetes prevention model to be more effective. As we talked in the last panel, as they talked about, when you look at the outcomes for these populations, you see you don't see the effectiveness that you see overall. And so we need to do something to increase that effectiveness in certain populations. And then also natural experiment studies. So in those instances where we cannot, demolish neighborhoods, we actually try to study the before and after of revitalization and, the implementation of food stores in neighborhoods. So I've been involved in a couple of those studies, particularly one called the FRESH study that is looking at neighborhood revitalization from a number of perspectives: grocery store initiation, built environment, and housing, and how that contributes to cardiometabolic control.
Thank you. Sorry, I disappeared there for a moment, but I am back. I'm glad you moved ahead without me. And I'll turn now to Joe Selby for just a few minutes of introduction.
Thanks, Alan. Nice to see everyone here. I'm Joe Selby. I spent a long career studying diabetes and evaluating things like care management, mail order pharmacy, treatment intensification programs within care management, and I spent a lot of time in performance measurement and trying to improve performance measurement. I think the authors really need to be congratulated for this series of papers. They are quite thoughtful and very useful, and they do update, for me, where I left off about 10 years ago when I went to McCourt. But I have to say that I do have a feeling that progress has been relatively slow over these last 10 years. And as Dr. Wang said, we have not yet found a magic bullet. A lot of these efforts show very modest impacts at best. And as the paper that Mo presented by Dr. Chehal et al. Indicates, with a background of the kind of fragmentation we see, it's not surprising that health systems have trouble mounting meaningful, consistent, reliable interventions for whole patient populations, and also mounting the kinds of studies that would really show the effects. So I want to make just two brief comments, and one of them really that are very distinct, going very different directions, but are complementary, I think. And the first has really been addressed by Dr. Agadi and also by Tiffany, and that is that diabetes is a social disease. And I just wanted to add on to what Tiffany said, that I think we have studied community health workers enough in enough different diseases that we know that people who are not medical professionals, people who are embedded in the community, probably people who are not even employed by the healthcare system, can make a big difference in the lives of patients with chronic illnesses, and maybe perhaps especially those who are particularly vulnerable, who are the victims of racism, poverty. So I think community health workers have the potential to link people to resources in the communities, as well as linking them to the healthcare systems. And maybe we could discuss this a little bit more, but healthcare systems are not ideally suited for addressing social diseases like diabetes. The other angle that I'd like to mention and really emphasize, and hasn't been mentioned at all yet, is that one good reason why all of these interventions look to be rather modest in effect is because they probably have no chance, if you think about it, of working for all the people in the study population. One size never fits all. Even mail order pharmacy, which was a potent factor for improving both adherence and risk factor control in every study I've seen, doesn't work very well if you don't have access to a mailbox and secure mail delivery. So we used to not be able to study that very well because we'd have to just study one risk factor at a time, how the treatment worked, the so-called interaction. But there are improved statistical methods now for analyzing data to look for treatment heterogeneity. Sometimes treatments are more effective simply because the subpopulation is at higher risk. And so that you get more bang for the buck in the higher population is sometimes the, but instant absolute not the right answer. Don't benefit. They may be too sick, unable to respond, not able to take part in the kinds of self-care that are promoted in interventions. So greater use of these new analytic methods in both observational studies and in analyzing the clinical trials to find out what works for whom has the promise of finding subgroups that really benefit substantially from particular interventions and tailoring the interventions to patients with certain characteristics. And I think this is particularly relevant to subpopulations that are experiencing social vulnerability, health disparities, and the effects of racism. So thanks.
I'm in and out, which is making me very nervous, but I'm in right now. So Mark, I'm going to turn to you before I lose.
Alan, thank you. It's a pleasure to be on a panel with Drs. Ali, Gary Webb, and Dr. Selby. And Alan, I want to thank you and Don and Sarah and Debbie and the Forefront team. It's remarkable, and I hope a lot of people have acknowledged that many of the key studies in this area have been published health affairs over the years. And I can't start a presentation without quoting my mom, who said, "I can't believe you had to spend $1 million to show that if you make people pay more for something, they'll buy less of it." And the idea of VBID, which I'm so glad to hear you use the acronym, value-based insurance design, is all about removing financial barriers. And it was Health Affairs that published the first VBID study in 2003. There have been VBID studies on diabetes, on low-value care, on equity, all published in Health Affairs. And to be today to talk about prevention, care, and outcomes for diabetes is a great pleasure for me. Dr. Ali, I'm not sure you should feel better or worse, but I just recently chaired an NIH panel showing that we're not doing as well as hypertension either, which may be even easier to diagnose and treat, particularly among underserved populations than diabetes is. So this is a systemic problem. It's as you look at that continuum of prevention, care, and outcomes. So the first part is, as Alan knows, I had the great honor to be involved with the writing of the preventive care mandate of the ACA, which now covers 80 services first dollar, including diabetes screening and the diabetes prevention program. But of course, if you're diagnosed with diabetes, even with a free test, it doesn't at all ensure that you'll get the care you need. I'd almost rather not know someone has hypertension, diabetes, or even certain cancers, and not know they're not able to get the care they need. And in fact, if you look at the coverage of some of the most notable quality metrics for diabetes, such as diabetic eye exams, which I've been studying for decades, coverage for diabetic eye exams across the board in the US is actually worse in 2022 than it is in 1980s when I started studying it because of the growth of deductibles and blunt cost-sharing instruments. So I completely agree with Joe that all things about healthcare should be targeted. I've said for decades that personalized medicine needs personalized benefit design and personalized payment reform, all ideas that have been mentioned in health affairs. And I think it's also important that despite the emphasis now on prevention, prevention is not enough, and that we actually have to focus on people who are diagnosed with either precursors like diabetes prevention issues or obesity, or the management of diabetes itself. So my second most tweetable soundbite, and I don't have anywhere near as followers as Alan does, is my patient should not have to have a bake sale to afford her insulin. And that has been the rallying cry for value-based insurance design to reduce out-of-pocket costs for essential services. Alan, your timing is always great. You probably heard last week that United announced with great fanfare that they were removing co-payments and deductibles for emergent services for which there's not overuse, like insulin and epinephrine and naloxone. But as you also know, Pitney Bowes started doing that with us in the 1990s. There have been a number of public and private payers that have put in this idea of clinically nuanced cost sharing. Many of the evaluations published in Health Affairs. But remember, free is not always the answer. As we've heard from Dr. Ali, is that there's many other barriers, and no one knows that more from myself covering the issues around COVID-19 vaccines, in the fact that the ACA VBID mandate was actually used by Congress to make COVID vaccines free. So a couple of just brief updates to what's happening in the space of nuanced payment and benefit design. First, in the commercial space, we've had significant reforms driven by the previous administration to allow diabetes care to be covered on a pre-deductible basis in high deductible health plans, to which 75% of employers and 75% of plans have changed their benefit design to make people with diabetes pay less, not only for blood sugar lowering agents, but also antihypertensives, as well as lipid lowering agents. The Medicare Advantage value-based insurance design demonstration goes beyond lower cost sharing for visits and drugs and addresses some of the issues that Dr. Egidi mentioned. The first program to cover nutrition support, to cover housing issues like pest control and other non-medical benefits that also significantly impact the potential care and outcomes for diabetic patients. And I do want to just say one quick thing about alignment. Alan had the courage to allow me to publish a paper on the blog in 2015 talking about peanut butter and jelly. And to our colleagues from the University of Chicago, I talk about payment reform as peanut butter and consumer-facing engagement as jelly, and have said and known on Capitol Hill as the peanut butter and jelly guy, not because it's 1:30 in the afternoon on the East Coast, but I strongly believe that the alignment of payment reform and benefit design will bring about some of the ambitious goals we're trying to get. And to close out, it's just really interesting to me that something like the diabetes prevention program, perfectly covered, but horrible supply. Diabetic eye exams, really good supply, but covered really poorly. And the last thing I point in my second to last forefront blog is that if this administration wants to get serious about health equity, not just talk the talk, but walk the walk, we have to get serious about the precursors to diabetes, such as obesity, and get very serious about interventions that focus on underserved populations and Black and brown communities. And you can imagine what my mother said when I told her I had to spend $500,000 to show that poor people and underserved populations are impacted more by high prices than rich people. But thankfully, Alan allowed me to publish that too. And value-based insurance design, as shown in an analysis of a cardiovascular disease implementation, almost all the benefits of lowering barriers and cost sharing are incurred by underserved populations. So I'm hopeful as you put that brew together of multiple implementations, Joe, that will make this better, that you'll remember to reduce barriers for patients to get the care they need, and remember to allow clinicians to be rewarded by the time and resources to be able to make them happen.
Well, thank you all for those opening thoughts and situating yourselves in the discussion. I was going to start by talking about fragmentation, but actually, I feel like we've We've explained that one pretty well, and unfortunately, it's descriptive and not helpful. And so I want to turn actually immediately to work in the community. One of the questioners listening asked about the role of community health workers. We had a presentation, one of the papers focusing on care coordination and workforce. We've talked a lot about boundaries between medical and non-medical, and one of the places where those boundaries can be breached is in the community. So I wonder if we could start just talking about what would it really take to take a community-oriented approach to addressing the type 2 diabetes epidemic. Who would like to start us out on this? Tiffany,
So
looks
I'll
like you're
start
ready.
out. Yeah, I'll start out just talking a little bit about the work that we've done with community health workers and the fact that there is a strong evidence base on the effectiveness. Our work in African-American communities, again, it was partnered with nurse case managers. So the idea that the community health workers weren't going to take on a role that was medicalized, they were working inside the home with the participant and really being a liaison between the participant and the healthcare system. And so that was one of the main benefits that we found is that we improved people being in the emergency room. So we kept people out of the emergency room. We did have some improvement in clinical outcomes, but also in quality of life and different aspects of quality of life. So we really attribute a lot of that to the community health worker model. I wanted to say something else in response to the paper on non-medical interventions, because one of the things that I noticed is that the 10 papers that were highlighted there, most of those studies were still in the medical setting, and the interventions were conducted by medical personnel, whether it's nurses or so forth. So that really struck me about that paper. And so the one study that was conducted in food banks, and I know about that study because I was involved in the diabetes prevention version of it, but it was taking people and finding people in food banks, in the food bank setting, screening for diabetes, and then doing some education for diabetes self-management and diabetes care. That is one of the models that brings in the notion of community clinical linkages. So I think really that is where we have a good chance of bringing community and clinic together. So not the interventions mostly that we saw where the medical setting brings in some aspects of the social determinants of health, right? But really screening for the social determinants of health and finding resources in other places. So the food bank study is an example of finding people in community and linking them to care. And there's a lot of examples of the other way around, screening for social determinants of health within a clinical setting and then referring to community-based resources.
Alan, if I could just add on a little bit to what Tiffany said. I think this idea of healthcare system community partnerships or interactions is fundamental and not nearly widely practiced enough yet. But to borrow from some of the engagement literature that PCORI was funded boatloads of, it really takes mutual respect and an equal status. You cannot be a healthcare delivery system telling the community what they need or, inflicting your idea of what works for you onto them. So that's really radical and transformational. It needs to be emphasized. That's not going to be easy or just another meeting. The second point there, to borrow from the paper on alternative payment models, is that I think that systems that get involved in that fourth level of payment where they are fully responsible financially for hospitalizations, is a system that's going to be more motivated to take these kinds of strong, make these overtures to the community and get involved, because they actually are going to be motivated to keep those patients out of the hospital. So that's it.
Mark?
Alan, so I have about mixed reviews from my close colleagues here. So first is, let's remember that the diabetes prevention program started in a YMCA in Indianapolis, Indiana, right? So it was the ultimate community-based program. But you knew me as an extrovert, Alan, but I've become introverted and somewhat of a homebody for the last 28 months. And was a proponent of telemedicine and virtual care long before we needed it in COVID-19. And it was a major part of the MAVBID demo. And I'm very happy to see it not only in my own practice as a general internist, but we can do a lot of management and reach a lot of people, not everyone, but more people in the extension of virtual and telemedicine care, specifically for diabetes. I think the management of hypertension is perfectly set up for home-based care, as is many, not all, not foot exams, not eye exams, but many of the aspects that come with the area of the management of diabetes. So while I'm all in for people who want to get engaged with their community health center, and I work with FQHCs very closely, I do think that the bigger opportunity is seeing what's happening on Capitol Hill regarding the expansion of bandwidth and allowing some of these dietary, clinically oriented companies with tech support that may allow some people that I'm seeing who actually manage some of their chronic diseases better, largely because they don't want to see me face to face. That's only half true. But I don't want to go back to where we were in the fact of making people who are working 2 jobs and working night shifts and all these other things to be able to come in for those 11 minutes that Dr. Ali would talk about, when we could really reach a lot of people where they are in conditions like type 2 diabetes, as well as others that we see in primary care.
Tiffany, go ahead.
Yeah, I just wanted to respond. So I do agree that telemedicine will provide more reach. I do want to caution us on that in the fact when you're talking about Black and brown populations, underserved populations, that in-person support is one of the critical pieces of success. And we know that the coach is another critical, indicator of success. So I would want us to balance the idea of a larger reach with, more intensive outreach. Just as an example, when we did the food-based banked diabetes prevention study, we actually had a model where we said, instead of doing things in-house at the food bank or so forth, we would refer to the existing diabetes prevention programs, but the infrastructure was not there, right, to accommodate that. And so what we found is that a lot of the commercial programs that had online-based programs, they were the ones that were available, and we did not get the uptake that we really needed. Particularly, we had a lot of Spanish speakers, and so we didn't have a lot of accessibility there. So I just caution us to balance those, the reach of the telemedicine with the intensity of the outreach needed.
Yes, before I turn to Mo, just to also say that, different services and different types of services can be provided in different modalities. And so we don't need to sort of say this is either telemedicine or not. We can talk about what is based and rooted in the community and builds the relationships and has a higher touch point, and what is not. And again, a well-designed, non-fragmented system should be able to help us navigate those. But it is an important tension point. Mo, I'll turn to you.
Yeah, no, Alan, I think I was going to say a very similar thing, which is to say that, if Mark is an introvert and wants to get on a lifestyle program that is virtual and Tiffany wants to be in person, I think that precision public health thing that Joe brought in is really critical, especially in today's environment with so much data. My question, I guess, to somebody like Mark, or maybe even Joe, who could take this is, as you think about the peanut butter and jelly model and trying to make sure that you have a system in terms of payment and policy that actually works and is aligned with the goals of patients and their clinicians, how does precision public health fit in there? And does it basically make, I used the phrase earlier, a paella out of something that was much simpler earlier? And do you basically get a really complicated mess and much more admin need?
So
well, I'll go first because Joe, can I go first? Because you have the real experience. I'll take on this.
Okay, sure.
So Alan knows that when I talk about we need to buy more of the good stuff and less of the bad stuff, Mo, everyone's all for that. Republicans and Democrats, management and labor, we've been very easy. It's just deciding what are the high value things and low value things, which is I have largely taken the position of not the controversial items, and not even the low lying fruit, but the fruit below the ground. Services that have been identified as, say, A and B services by the U.S. Preventive Services Task Force or quality metrics in every health plan, also known as a diabetic eye exam, right? That should be profitable and easy for patients to do, neither the case, right? And the same holds true for low value care. And Alan was nice enough to kind of encourage me because I was chagrined to become a low value care guy. But the U.S. Preventive Services Task Force that says things are so good they have to be free under the ACA. There's also a D-rated type of service of the task force that says these services are so dangerous we shouldn't be doing them at all. And we're spending hundreds of millions of dollars a year on each of them, particularly on Medicare folks. So we have to start somewhere. And we argue on the things where there's lack of clinical controversy, and we should pay clinicians more and intervene in public health on those things that we know work well. And finally have the courage to stop buying the things that at best are not making people healthier, and in many cases are actually harming individuals and populations.
So I'll take a stab at your question, Alan. Which is, are we just going to have a fragmented basket of interventions that we try to direct at the right people? Well, perhaps, but there's a nice paper that came out of Kaiser, my old workplace, about a couple years ago, a health services intervention, a care management program. And, Kaiser, like many people, had assumed that, and this is to keep people out of the hospital, had assumed that you probably ought to go after the high-risk people, the people that are most likely to be re-hospitalized, and plan your intervention for them. When they really analyzed the data, it was a kind of a stepped wedge design. They found out that the people who were at the highest baseline risk didn't respond nearly as well to the intervention as people who were kind of in the middle. And there's actually another guy, Don Redelmeyer in Toronto, who likes to talk about the sweet spot for these interventions. So it's really common sense. This is not rocket science. Doctors know that some people are too sick for a particular treatment on the individual level, but on the population level, we need to be able to identify that. And my point was just that we are now increasingly equipped with the analytic methods to do that, so that you would have a disease management program that targeted people on the basis of their perceived benefit, not just their perceived risk. And you direct an intervention that had been shown to benefit people like this person. And even community health workers may not be very good for, employed suburban folks. It may not work, period. And yet it does for others. So getting the right interventions to the right people is what doctors have been doing for a couple centuries. And but we need to take it to the level of health services interventions and to the level of policy.
I was really taken by the paper that talked about rethinking quality measure, but I'm also daunted by the idea of reconfiguring quality measures. I don't have a rolling off the tongue acronym like VBID, but I kind of want value-based quality measures, which would be VQUM or something even worse than that. It does make me wonder, and I'd really love, particularly since we have clinicians, and I am definitely not one, don't even play one on TV. How far in your, from a more clinical perspective, how far are we in the standard metrics from what would be useful to capture precision public health, to capture this this notion of the sweet spot, to capture the leaving behind of low value? Those from the paper, I have a sense that we're just so far away from where we need to be. And I know measuring quality better doesn't make quality better in and of itself, but it could be a very effective tool. Anyone want to weigh in on that endeavor?
So I'll start quickly, Alan. I'll just say this. I'm a demand side researcher largely because payment reform has proven so difficult for so long. Upton Sinclair said, it's difficult to get a man to understand something if his salary depends on him not understanding it. This is the case when we started many decades ago. It is still the case now. You are at the forefront, pun intended, with many other folks who are trying to move America away from fee-for-service. But until we do that, folks like me and many researchers are really working at the edges. And I like that most, if we were able to get a situation like what Kaiser professed in its founding, that we will reward you and make people and populations healthier, and we won't reward you if you don't. I haven't seen that come to fruition. I know that's just the start of what you wanted to say, but a quality metric, a diabetic eye exam, my friend, has been around for 50 years. And because it's hard for people to access an ophthalmologist because the benefit design and payment structures don't encourage them, as opposed to high-tech lasers and other types of things, I tend to be Tigger on most things, but I'm somewhat Eeyore on a lot of these issues.
Joe?
Good. Yes. As I said, I worked a long time in quality measurement, in part because it's so intellectually interesting. The idea of whether you should use a continuous or a dichotomized threshold, or whether something is really evidence-based and whether process measures are better now. Yeah, you could sit around for days and months and weeks, years, and people have, and people do. In fact, I would say that the quality measurement industry is a huge ocean liner at this point, and it's hard to move the quality measurement industry. And the one thing that I think might have some promise would be that if we are going to embark on another generation of developing new, better quality measures, we should have the people on whom they are going to be inflicted, that is clinicians and patients, at the table from day one, so that we don't get into these intellectual discussions as much as we get into, does this make sense? Would I be moved by this? Do I want my care to be evaluated in this way? So engagement of the people who are going to be affected is not happening at present, hasn't happened yet to any meaningful extent, and absolutely must if we are going to go down the road of finding a new generation of measures.
Mo, yes.
I think the other piece is that, and this was the third area of fragmentation that we talked about, is sort of information management in America remains very much proprietary to what payers have, what systems have, and very little of it is actually what patients have of their own, even though it's their own medical record. And I think there is something to be said for, as we think about this new generation of matrices, we've got to find ways to either do better interoperability, which PCORI has already sort of ignited about a decade ago when they started those PCOR nets, which is that they funded different systems to share data and find interoperable measures. But I think we need to go beyond that. I think we need to go to the Amazon level of everybody has their own cloud that will follow them anywhere in the country and is accessible by any EMR to download everything that's happened to you in your past and help a clinician help you go forward into the future. And not only that, be able to be deposited in some awesome private way so that we can do population health in a better way and that we can get these quality metrics out of it for all Americans, not just those who have employer-based insurance who move from system to system. And so I think that's another critical piece, but really tough to do, and I think would need federal investment. Nobody else is going to invest in it.
Correct.
So that still sounds very clinically oriented, walking around with your own EMR and having clinicians have access to the data, better than not having that, but still a far cry from the integration that you spoke of at the outset. I do wonder, as we come toward the end, I have this image, and I'll just ask you all to maybe make one policy recommendation out of it. We heard every day for the last 2 years that COVID showed the weaknesses and the disparities in the American healthcare system. It did it in a very short time, but I think the story from diabetes is that it also shows us the weaknesses and the disparities and the underlying inequities in our society. And it just does it more slowly. And so it's easier for people to ignore, maybe is the way to say it. So the upside of the first sentence is that people say, well, COVID is shaking us up and it's leading us to do new and different things and creating opportunities, telehealth being one, Mark, you already referred to. So I guess my closing question to each of you is there something that we've learned from the harsh, quick hit of COVID that maybe could be applied to the slower but equally damaging hit of diabetes that we could take away as a lesson for policy or practice improvement? And each of you gets a stab at it, and then we close it out. Who wants to go first?
Well,
Tiffany.
yeah, I'll start just because I've spent the past 2.5 years in transition to COVID equity. And so, and it was not intentional. It was because, we recognized early on that there were these disparities and that we had to take action. And so what we did here in the Pittsburgh area is we formed a Black Equity Coalition. And we have really worked on equity issues from so many different places. And I'll just focus just on the data piece because I'm an epidemiologist. There's lots of community action and advocacy, involved with that. But just thinking about how fragmented, and even our health department data systems. In the beginning, we could not even get access to the data. So there are a lot of different, data coordination pieces that can happen. And then what we've also done is had a data intermediary approach where we who work with data have, and who are a little bit more community oriented, we actually work with communities to show them data and make action. So those types of data integration strategies, I think, would be one lesson learned.
Great. Thank you for starting us off. Mo.
If I can work off of that, partly because Mark scared me away from the idea of sort of supply side payment reform, but also because I think it really does start to get us away from a very clinical focused approaches. Same thing, I think information management, I would go one better than what I said on the Amazon account that you carry around with you as an electronic health record, but more as a record that you can use in communities. And I think COVID is that example of that we didn't know what people were doing from a self-testing standpoint, from a PCR testing standpoint. And if you do focus on information management that helps us track people through stages of life, through places where they work, live, and play, and go to the doctor, I think that'll do a lot more for getting us less fragmented and maybe even pushing us towards better healthcare service delivery and payment.
Thank you. Mark or Joe, closing thoughts. Mark.
Thank you, Alan. So your staff is amazing. They tweeted my second most tweetable soundbite, so I'm going to start with my first. So Americans don't care about healthcare costs. They care about what it costs them. And there's been a very important takeaway from COVID in the fact that as I travel virtually around the country and ask people what it cost them for the COVID vaccine if they elected to take it, they say zero. They don't say that Pfizer and Moderna and the government said 28, 22, whatever else. And I think as someone who's been trying to lower out-of-pocket costs for high-value services, particularly around diabetes for 3 decades, I think the fact that people like the idea of getting services they deem as valuable without having to go into debt. And I think we could grow on that. And you sitting in Washington realize that the insulin copay cap legislation, which is being held hostage in Congress, emerged out of a VBID center-initiated program called the Senior Savings Plan in Medicare that has benefited millions of beneficiaries in the Medicare program, many of which from underserved populations. So I think we could build on this idea of not only low-cost COVID vaccines and insulin, but extend this to preventive services, those that manage, very exciting things going on in the area of obesity treatments and interventions, and also some things that you're going to see, I'm sure, in the journal soon about actually reversing type 2 diabetes through tech-supported programs. So I am always Tigger, as you know, and think that we can take a silver lining from the pandemic of what we learned in telemedicine and COVID vaccines and apply it directly to diabetes.
Well, I really like what everyone else has said. I would only add, I think I've felt from almost the beginning that that the COVID pandemic was really a mass epidemiology course for the nation. And, everybody knows infinitely more about things like testing and prevalence and incidence and treatment effectiveness. So it is dramatic. So it's a good moment. I think two things to take away are, number one, these disparities that we've been talking about are everywhere, and they will come out in the future if we don't plan differently. So that, having the COVID experience under our belts and understanding disparities even more starkly now, we need to build this notion of eliminating inequities into planning in the future much more than we have in the past.
Well, Drs. Ali, Gary Webb, Selby, and Fendrick, thank you so much for such a rich discussion. Really a pleasure to be able to lead you through it. Not that you needed my guidance, but we covered some great terrain, and you left us throughout with some outstanding matters to think about with respect to policy, which of course is our focus at Health Affairs. To our audience, I encourage you to look at the July issue for more detail on the papers that you heard presented and other content as well. Of course, we do a lot more than publish papers. We have a website that will link you to our podcast, to future events and more. And speaking of events, tomorrow at 4 o'clock Eastern, if you're a Health Affairs insider, you can join us for July's Journal Club featuring authors Morgan Henderson and Morgan Muslim talking about emergency facility fees. Health Affairs Insider is a membership program, so we encourage you to become an insider and participate in that. And then on August 3rd at 1:30 p.m. Eastern, we have an open policy spotlight with FDA Commissioner Dr. Robert Califf that I'll be moderating. Again, thanks to our authors from the first panel, our panelists for the second, to Eli Lilly and Company for supporting publication of this set of papers in this event, and to our audience for participating and listening in. And with that, we are adjourned.